Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and the Unstably Housed, sponsored by the Southeastern National TB Center. Today's speakers are Dr. Sapna Morris and Bobby Watts. Dr. Morris currently works as the team lead for the medical consultation team of the Field Services Branch within the Division of Tuberculosis Elimination at CDC. Sapna joined CDC in 2006 as an Epidemic Intelligence Service Officer with the International Emergency and Refugee Health Branch in the National Center for Environmental Health, an assignment that led her to work with displaced and affected populations in Kenya, Nepal, Vietnam, and Azerbaijan, Thailand, and Swaziland. In 2008, Sapna took a full-time medical officer position with the Outbreak investigations team within the Division of TB Elimination. Since that time, she has been involved in numerous outbreak responses as well as operational research, with a particular focus on TB in persons experiencing the homelessness, multi-drug-resistant TB, and disease affecting the residents of the U.S.-affiliated Pacific Islands. Sapna completed her residency in internal medicine at Case Western's Metro Health Medical Center, fellowship in infectious diseases at the Cleveland Clinic, and physician executive MBA focusing on healthcare policy and financing at Auburn University. With a background in social work before attending medical school, Sapna has volunteered extensively with homeless service providers over the last 20 plus years in Milwaukee, Cleveland, Washington, D.C., and now continues that work with Mercy Care of Atlanta. G. Robert Bobby Watts is the Chief Executive Officer of the National Health Center for the Homeless Council. The council supports the 300 federally supported federal health care centers for the homeless programs, and also medical respite providers with training, technical assistance, sharing of best practices, research, and publications. The Council has an active policy and advocacy program working to eliminate homelessness. Bobby is a nationally recognized advocate and leader in meeting the health needs of people without homes. Watts has 30 years of experience in administration, direct service, and implementation of homeless health services. He spent most of his career prior to joining the council at a Healthcare for the Homeless program in New York City, beginning as an intern and serving as the executive director for 12 years. He has served on numerous boards and government-appointed task forces and councils. Bobby is a graduate of Cornell University and the Columbia University Mailman School of Public Health, from which he holds a master's in public health and in health administration and a Master's of Science in Epidemiology. He also holds a certification in public health. Today's moderator is Dr. Connie Haley. Connie is an infectious disease physician trained at Vanderbilt University. She has worked in TB since 2001 and now works as a medical consultant for the SNTC. Now I will turn over to our presenters, Dr. Morris and Mr. Watts. Dr. Morris, you should be able to share your screen now.
Thank you very much, Linda. I have shared my screen.
I want to switch, if you can click the display setting and switch your two screens, because we have the presenter mode right now. On the top left.
Okay. Is that right now?
That's correct.
And remove the Skype for Business.
Oh, sorry about that. All right, I'm going to try that again. I apologize. Okay. Is that correct now?
That's correct.
Okay. Thank you all for inviting me to do this. I appreciate it and apologize for my slightly hoarse voice. Try and make it through without coughing, although that might be appropriate for a TB talk. Do want to thank, Connie and Donna and everyone at SNTC for putting this series together. I think it's a great collection of topics, and I think TB disease among people experiencing homelessness fits right into the idea of all the things that plague our patients, in addition to this kind of dreaded disease of TB that they get. So without further ado, I will just kind of briefly touch on the objectives of this talk. My goal here is really to help folks that work in TB care really understand the kind of current milieu of homeless services out in the country right now, and a little bit about what's going on in the world of homelessness in the sense of the trends in the country and their kind of broader context of receiving care around their health. So to that end, I wanted to try and define unstably housed individuals to enable healthcare professionals to recognize and appropriately manage their TB-related health needs, but also their other health needs. Describe how substance use, mental health, and incarceration increase TB risk among unstably housed individuals, and so that we can design appropriate interventions and apply them, and then identify measures to improve housing or stabilize social situations for individuals with TB infection or disease, which can only facilitate adherence and safe completion of treatment. So those are lengthy, but do encompass kind of all the objectives. And I may not touch on every single one directly, but I think hopefully you can also ask questions if you need be. So again, just to touch on the overall intersex of folks that are having to live in the status of being homeless, what the kind of intervention of housing, how it impacts health for these folks, and that directly leads to a approach right now that is really first and foremost in the homeless service world, which is housing first, and we'll talk about that. And then how does that impact our TB care for our patients who are experiencing homelessness? So in the U.S., about 1.3 million people are experiencing homelessness. The U.S. Housing and Urban Development Division publishes an annual report called the Annual Homeless Assessment Report. The last complete report has been published for 2016, but we have some preliminary data for 2017. These numbers are based on two different systems. One is a series of surveys that are done in a week in January every other year for reporting to HUD. It's called the point in time count. Many of you are probably aware of these surveys or counts that go on in your jurisdictions. They do them every year in most jurisdictions, but only every other year do they get reported officially to HUD to compile for an annual homeless count. So they use that point in time count to really try and look at trends and understand the proportions of folks that are either sheltered and homeless, are living on the street, are unsheltered and homeless, potentially are chronically homeless, and for those that are living in families or in other situations, but really are still considered homeless. And in addition to the point in time count numbers, which really gives us a snapshot of 1 or 2 nights in a year, there is a homeless information system. It is a surveillance system that's used all over the country, and it does report demographic data about people who are applying for housing needs. So if individuals in a jurisdiction who needs to have temporary housing or emergency housing, or needs to apply for more permanent housing, they may all be entered into the Homeless Information Management Information System, or HMIS. Those data are held locally and owned locally, and then are reported up in a de-identified and deduplicated way to HUD, and through statistical analysis, they're able to come up with a more estimation of an annual number of people who have experienced homelessness in a given year. So that's how we kind of end up at this number, and we'll talk a little bit about the point in time number in just a second. Nationally, about 7 in 10 homeless people were in shelter, so we do see more folks that are sheltered than non-sheltered. The majority are not chronically homeless, so it still is the case that more people experience homelessness and are able to get out of that situation of not having a place to live over a time period, as opposed to those that may end up living more chronically, either unsheltered or in shelters. But we really want to think about the larger population that is kind of at risk. These are folks that are unstably housed, who may be moving or couch serving frequently, who are often kind of in and out of correctional facilities, may have issues with substance use or mental illness. And so while we really do look at the risk among people that are currently homeless, that 1.3 million in a given year, we do know that there are millions more that are kind of subject to the state of homelessness in these other kind of populations that may overlap. So if you look at kind of a snapshot of homelessness in the U.S. Based on HUD's most recent numbers, the point-in-time count that was done in 2017 reported about 553,000 individuals who were homeless on a given night. Of those, the sheltered proportion was about 360,000. So most, again, over half of the folks are sheltered. And then you can see a breakdown by household type and sheltered status. I won't go individually through the numbers, but you can see that there are still a significant number of people living in families who are homeless. Most of them are sheltered, and then about 65% of the total population are sheltered. And you can see that there are more, about 35% that are individuals who are unsheltered. And then just as a kind of a summary, for every 10,000 people in the U.S., 17 were experiencing homelessness. And as you can see, the overall change on the bottom table here from 2016, the number of people that were homeless went up approximately 1%, and that's actually after a number of years of it going down. The number of individuals went up 4%. The number of families with children went down about 5%, and the number of veterans went up 2%. And that's again after a number of years where we'd seen that number decline. And the individuals with a chronic pattern of homelessness has gone up actually by 12%. So I do encourage everyone, these annual homeless assessment reports are available online. They do break things down by state and by jurisdiction, actually by HUD's division of their grantees, which is called the continuums of care. We'll get into that a little bit more later. But I do encourage you to look at your own numbers and understand kind of the populations in your jurisdiction. I think it's an important baseline understanding of what's going on in your communities that can really help. And, you know, what we know is that folks that are living on the street or in shelters often have, they're dealing with multiple medical problems, and often in worse conditions than their housed counterparts. And I think Bobby will get to that a little bit more in his section. But some of the most common diagnoses that we see, hypertension, mental illness, as we know, heart disease, diabetes, asthma and COPD, hepatitis C, 3% for HIV infection, which is quite high. Traumatic brain injury is something that I think only in the recent years have really understood how much of a large proportion of the population that's impacted by traumatic brain injury. And then, of course, STDs. There are a lot of barriers to care. I think Bobby will talk about his network of clinics that he works for and with that really do an amazing job of trying to reduce those barriers. but we still see problems with transportation, the need for identification or a letter to show that you are actually homeless. Obviously, just the access to care. There's still stigma and fear of authorities. Certainly, there are problems with storage of medications or continued access to those medications. The time that it often takes to be seen, the difficulty in establishing a primary kind of healthcare home, and then one of the biggest problems we see is an access to subspecialists, which I think is a frequent problem all over the country. So as you can see that, as our rates of TB have declined, you can imagine that for someone who may have a traumatic brain injury and has diabetes, hypertension, and heart disease, whether or not they have latent TB infection and have the potential to progress to TB disease may not be on the forefront of their mind, as well as the provider that might be focused on this population may be worried about getting these other things addressed before they're thinking about TB. And so, as it's been said to me by a shelter provider or director, until it's a problem, it isn't a problem. And then, once it becomes one, it's a big problem. So I think we have to take into consideration when we're talking with our partners in homeless service agencies that they have a lot of other things to worry about. And it is already challenging for many of our patients who are experiencing homelessness to prioritize some of their healthcare needs over some of the more basic things needed, food and shelter. However, these things are obviously impact their overall well-being and their morbidity and mortality generally. And so we have to kind of put into context what we're concerned about, which is the potential for TB. So Dr. O'Connell, who's been a long time healthcare for the homeless provider, shares this slide, and he was kind enough to share it with me, that one of the things that when you kind of work with people that are experiencing homelessness and you're trying to address their healthcare needs, whether it's focused on tuberculosis or otherwise, you often find yourself saying, that if you could provide them the housing and the stability to be able to access more of their care in a consistent manner, and they could not worry about where they're going to have their next meal or where they're going to be staying overnight, that in and of itself would improve their health. And that has actually been shown. And so Dr. O'Connell often shares the slide that if he could, this is the prescription he would probably give all of our patients, and for good reason. And the data has really kind of shown that out. Over the last, 15 or 20 years, I guess, we have had a lot of agencies that have kind of shifted how we look at addressing homelessness on the national level. And just to give you some awareness, during President Obama's first term, he did create the United States Interagency Council on Homelessness. They drafted a national plan to end homelessness called Open Doors. And their initial focus was ending veteran homelessness and then ending chronic homelessness and ending homelessness for families. They have actually, their membership is made up from every cabinet, and they continue, they're a small agency, but they continue to do a lot of coordination at a higher level around how we can bring together the resources to at least focus on these very at-risk populations and try and reduce homelessness in a very targeted way. And they've had quite a bit of success over the years. There were a number, over 700 communities across the country that were able to end veteran homelessness in their areas. So we've seen some improvement, and they are a tremendous advocate. In addition, the National Coalition for the Homeless, the National Alliance to End Homelessness, National Law Center on Homelessness and Poverty, a number of faith-based agencies have all been working on and expanding their focus around advocating for folks that are living in homelessness. So they've kind of initially may have focused on the whole shelter piece of it. Over the years, I think they have seen that you cannot address homelessness and health without kind of talking them in concert. And so all of these folks have really worked with us at the Division of TB Elimination to kind of think about infectious diseases like tuberculosis and how we can address these things better. And we are still actively working with all of them. And I have to point out specifically HUD, because we have a very active relationship with HUD. they have shifted their entire focus and have really added a piece of it looking specifically at healthcare and how health needs to be addressed, even in their emergency shelters, so that we're preventing further illness and further debilitating injury to folks that are trying to kind of get on that trajectory to more permanent housing. So we have a very strong working relationship with HUD, and we continue to work with them very frequently. So I want to explain kind of a little bit. Many of you probably know, but there's a kind of a newer approach that HUD has adopted. There were many demonstration projects that kind of proved that point that Dr. O'Connell made, that if you provide people housing, their health will get better. So housing first is this concept that housing is the intervention that will result in improving health and improving the life, overall quality of life, as well as length of life for people who are experiencing homelessness. So historically, when the concept, there was a lot of time and energy and money going into shelters and transitional housing. So the very, I think, real example that we've all experienced is we have a lot of patients that will come in for TB screening when they're entering a substance use treatment program. And often they were in a transitional housing program or a program where they would be required to demonstrate 6 months of sobriety and some work training in order to then be placed into permanent housing or semi-permanent housing. And I think a number of demonstration projects in the 90s really worked, and early 2000s really worked to show that the concept that folks are going to have their mental illness or substance use or their health addressed while they're still on the streets or in shelters, and then they could get into more permanent housing, was potentially a little bit backwards. And so the concept of let's give folks a more stable environment to live in, more stable access to food and safety, and then give them the resources to address their health problems, was really the right way to go. And demonstration projects have really showed not only that this worked in terms of improving people's overall health, but it also showed about 80% retention. So if you can get folks, even if they're quite compromised at the time that they enter their more permanent housing, that they are much more likely to be able to manage a lot of their multiple problems and able to retain that housing through getting their mental illness or substance use or other problems addressed while they're in the housing. So this kind of approach has really become the cornerstone of how HUD has supported their continuums of care across the country. And so what I mean by that is their grant recipients, your jurisdictions all over the country, when they apply for funds for supportive housing for their jurisdiction, they used to proportion it so that there was a lot of money that went into emergency services and transitional housing, and maybe a block of money that went into semi-permanent housing and permanent housing. And that's really shifted to now HUD is supporting a lot more housing first programs and investing in those types of programs and much less into transitional programs. So the concept, again, that the agencies that are working to house folks are really working to get them into some kind of semi-permanent or permanent housing, and then assisting them on the back end of trying to access the services. So that approach has really become kind of the mainstay across the country. So how does this all kind of impact TB and TB care? Well, one of the things that we've found is that outbreaks involving persons staying in overnight homeless facilities continue to challenge our TB control efforts. And so when we look at overall the TB kind of issue among persons experiencing homelessness, not every patient is the same. Not every housing situation is the same. And so there are certain circumstances where patients that may be in unstably housed situations and they are, quote unquote, couch surfing or moving from house to house has an impact on the contacts, but it doesn't necessarily increase that person to having risk of it being infected with TB. So where we see the situation escalate from a person who might have TB to an outbreak of TB is really when we see congregate settings involved. So whether that's large shelters or correctional facilities or like SROs or other kind of single room occupancies or transitional housing places that might have a lot more people in a program, that's where we tend to see, TB really still take hold in this population. So one of the things that we've really been stressing is the most efficient way of combating that problem, which is really the uptake of administrative infection control measures. And when we've tried to look at our shelters across the country or other homeless service agencies that might be at higher risk for having TB spread in their facility, there's really been variable uptake of these administrative infection controls. So I want to take a step back here. Sorry, I think that slide was a little out of order, and just talk about what TB has been looking like in the country. We all know this, I think, but over the years, as you can see from this surveillance slide, that the overall decline in TB is really reflected by persons that are born in the U.S. And there's been a very kind of steady decline. We're starting to level off now. But in our folks that are non-U.S. born, we have a little bit more of a steady incidence over the years. What I want to show overall here, though, is that the proportion of cases that are affecting our kind of at-risk populations still kind of remains steady. So if you look at the number of cases here over time that have declined in correctional facilities, as a percentage of total cases, it's remained the same and even gone up in some recent years. So that is to say, overall, the number of TB cases in the country is declining. Overall, the number of TB cases within diagnosed in correctional facilities is declining, but the proportion is actually staying relatively the same. If we look specifically then at TB cases reported among people who are reporting homelessness during 12 months before diagnosis, the same is true. So you can see, again, overall decline of TB cases in the country. There's an overall decline, quite steady decline here in the number of TB cases diagnosed in persons experiencing homelessness. But the percentage of total cases has gone down in the last couple years, but really at a slower rate of decline. So as you can see, in 1994, it was closer to between 5 and 6%, went up to maybe 7% at its most in the last 20 years, but now really has, only come down to a little over 5%. So it's still, the proportion of cases hasn't really changed that much. And then this slide is actually courtesy of Dr. Julie Self, who's been working on looking at the change over time. And essentially, like we've talked about, if you not only factor in the decline of overall TB cases, and then you also factor in the decline of the overall homeless population over the years, we still see the TB risk at an 11-fold difference. And so I think that's, in terms of a case rate, it still shows us that folks that are experiencing homelessness do have a tremendously higher risk of TB disease than the general population. So when we tried to calculate what that is, we were able to do this using that annual HUD data that I shared with you. So over the years that we were able to look at both TB surveillance data and HUD data, we calculated the TB case rate among persons experiencing homelessness at about 45 per 100,000. At the time that we had the data to calculate that, the national case rate was somewhere right under 4 per 100,000. So again, a 10 to 11 increase for folks that are experiencing homelessness when compared to the general population. When we look at specific jurisdictions, and I know some of you have published your data, we have seen as high as case rates as 200 per 100,000 or even higher. So I think it is important to note that while clearly people experiencing homelessness have numerous health issues to worry about, when it comes to risk of TB relative to the general population, this is still a big issue and can be quite devastating to someone who's also living in an unstably housed situation. And as I mentioned before, not all risk is equally distributed. certainly use of large shelters, chronically homeless, those who are HIV infected and often untreated, those who have chronic illnesses such as diabetes, and those who use substances are at higher risk. And as well as I showed you with the proportion of folks that are diagnosed in correctional facilities, those folks that are in and out of correctional facilities are also at higher risk for being infected with TB and progressing to TB disease. So when we talk about outbreaks, I think this is an interesting thing to kind of bring up from a programmatic standpoint. The folks that on our molecular epi teams have done a phenomenal job at kind of looking at how can these risk factors predict, when one case will become 3 and when 3 will become an outbreak. And so even when one TB case among someone who's experiencing homelessness is diagnosed, it requires more human resources and more financial resources in terms of the effort that it takes to not only diagnose that patient and provide treatment for that patient, but also to treat infection and contacts and even identify contacts. So that time and energy by your program certainly takes away from the preventive work of treating other TB infections. It potentially takes away or makes it harder to continue the care for your other cases that you have. And then contact investigations are often extremely challenging and time intensive. At least 1 of 3 genotypically matched cases in a geographic area who report homelessness or incarceration is actually the most predictive of an outbreak. So if you were to take, 10 cases in your jurisdiction or 20 cases in your jurisdiction, and you found genotypic matches between the 2 or 3, if any of those report homelessness or incarceration at the time of diagnosis or within the year of diagnosis, that's actually the most predictive of a potential outbreak. And so I think understanding that or learning early on that folks are within that kind of risk population can really help to guide your interventions, knowing that there is risk for those to become outbreaks of TB. Outbreaks involving persons staying at overnight homeless facilities continue to challenge our TB control efforts. So again, we talked about the uptake of administrative infection control measures. The key partnerships may not already be established, and so as you find out that there are a number of cases that are coming out of the homeless community, you may not already have a good relationship with the shelters or the faith-based organizations or the meal programs where these folks are frequenting. And so to work on those relationships in order to do contact investigations and things like that may be a challenge. Sometimes shelters and other service agencies are resistant to our TB control efforts or working with us, and at times because we may not always express our understanding of their belief structure, which is helping the folks that are living in homelessness is really their bottom line. And so there are a number of shelters out there and staff that work in homeless service agencies who truly believe, and I understand this concept, that providing that roof, allowing for people to come in and not be living on the street and not be subject to so many of the problems that folks that are living on the street face, that is the most important intervention. It gives them, that patient, that person, the time and energy to maybe have the opportunity to seek other help and seek other care if they need it, and keep them safe. And so when we are, as TB controllers and TB programs and TB providers, wanting to work with that shelter and maybe implement restrictions or implement testing prior to entry or some of the administrative controls, those interventions may potentially have conflict with the mission of the shelter or the service agency. And so we need to kind of work within that belief structure and help folks to understand that we're not there to impede their service or impede their interventions, but that we want also these places and these service facilities to be not also creating a situation where homeless folks are at more risk for something like acquiring TB infection or progressing to TB disease. So there's a lot of communication that needs to happen and a lot of compromise around how we work with our homeless service agency partners. And sometimes that takes time and energy. And so when we're in the middle of an outbreak doing that, it often delays our ability to control spread. So I do want to give some good examples of outbreaks because I think it looks different in different scenarios. So I think all of you are probably well aware of the Division of TB Eliminations. You know, we have an outbreak investigations team, and that we're not only asking you all in states and local jurisdictions to kind of monitor for outbreaks using your genotype information and your epidemiologic information. And so we hear about things from you all, from your epi work that you do. But we're also looking at the genotype clusters. And so we often identify them and talk with you about them, particularly if they're alerting us through our cluster alerts or through our large outbreak surveillance. And so often, you know, when the local and state capacity to investigate an outbreak has been exceeded, you all call us to help, and we'd love to actually be involved with you in helping to assist or investigate an outbreak that may be going on. And so this is actually our outbreak investigation team took some time to look over the investigations in this time period. We actually have a newer time period that we published about. I happen to have pulled this data, but over that 4-year period, essentially, CDC got involved with the investigation of 17 different outbreaks. And one of the things that was very surprising to us was that jurisdictions were most commonly calling us in previous years when in situations where we didn't necessarily have homeless people involved. And if you look from 2012 forward, something around 80% of the investigations that we've been now involved in have actually involved homeless persons. But when you look at the details of these investigations that we've been involved in, a number of them, I'm going to skip this slide, resulted in very, very difficult, challenging, and overwhelming contact investigations. So if you look at the patients that were predominantly non-homeless in these investigations that we were involved in, there were about 109 cases here that were involved in these 13 outbreaks that we were involved in, and some of them were multi-drug resistant outbreaks, so they were complicated for different reasons. But then if you look at the number of patients in 4 outbreaks that involved homeless patients, it's twice the number. And then if you look at the number of contacts identified, in 13 different situations that we were involved in helping to investigate, we saw 6,700 contacts. That's a lot. But then when you look at the contact investigations that involved patients who were homeless, we ended up with lists of 31,000 contacts. I mean, that's overwhelming by any standard. And I think part of the reason why is because it's very difficult to really be able to stratify contacts in the settings of large congregate settings where we don't have, bed maps, we don't have a way of kind of isolating who is really at risk when there's a patient with TB who might be contagious. And so it's just a reflection here of showing you that contact investigations and the subsequent work when there are outbreaks that involve persons who are experiencing homelessness is quite overwhelming, and it can really challenge the best of TB control programs to kind of mitigate the outbreak and address the situation. So here are some examples of outbreaks. So this is a suburban area, and I think this outbreak was really demonstrative of a reason to really think about treating TB infection in our contacts, even when they are homeless, and it may be challenging to do so. So in this situation, we had one case who was a confirmed case of TB in 2007. He was staying in a large shelter. There was a tremendous amount of work put into a contact investigation, and they identified no secondary cases at the time, but did thorough investigations to be able to confidently say that. This community is a relatively small suburban community, only really had 1 or 2 shelters and very minimal amount of homeless service agencies. It wasn't that big of a homeless population. But what was interesting is there wasn't a lot of movement of the homeless population either. So there were a number of chronic homelessly, a proportion that was chronically homeless, and also they didn't have a tremendous amount of kind of mixing with a larger urban area. So lo and behold, less than 2 years later, a secondary case gets diagnosed with TB with a matching genotype, and turned out epidemiologically reported being in the shelter at the same time as this case in 2007. That was alarming to the health department, but what really became alarming was the subsequent 14 or so cases that were then presented in 2010. And a number of these cases, almost half, were identified during the 2007 investigation, were found to not have TB, but there was no program at the time to treat TB infection among people experiencing homelessness. And subsequently, over the next 2 to 3 years here, we saw a total of about 35 cases that were all traced back. I mean, there was some, secondary cases that spread to tertiary cases and so on and so forth. But this all kind of came out of this 1 and 2 cases that started in 2007 and 2009. So this really, even in a relatively small suburban community, a relatively, similar kind of consistent homeless population in a relatively smaller area, this ended up being a big problem that overwhelmed the health department that on average saw 5 to 6 cases of TB a year. So this, you can imagine, was quite overwhelming. A second example was in a low incidence state in the Midwest, and this patient G, was unstably housed, and so ended up kind of couch surfing or going from house to house. A number of these houses had family members in it. A number of these houses had friends that stayed in it. But there were large family units in some of these houses with with many children. And so this patient was a musician and traveled around a bit and didn't really have a permanent address. It didn't kind of strike the health department initially when this patient was diagnosed that he was homeless, because he reported an address that he was staying in at the time he was diagnosed. He reported places that he had stayed. He didn't report himself as homeless. But then over the investigation and over time, as they talked with him more, they realized that the patient was, beginning to, or was staying in a number of different houses. And so the potential for spread became pretty overwhelming. And this is often what we hear from our lower incidence states or places in with rural homeless problems, that folks won't necessarily report themselves as homeless, but they end up couch surfing and causing problems by spreading disease in that manner. And then lastly, there's an example of 130 TB cases reported as homeless, but only 45 were linked by genotype and epi, and it was over time. And at the time when these cases were being identified, this was a larger urban setting, and there were 10 shelters involved. And because there were no bed maps and because there was no way to kind of triangulate who was really at risk, the contact list, when we pulled lists from the large shelters, there was almost 18,000 contacts who were potentially exposed to at least one of those 130 cases. When we tried to look at how can we stratify this, there were over 4,000 people that stayed more than 30 nights at the same shelter with at least one case who was contagious. So it's a tremendous amount of risk. It's very hard to then find 4,000 people who potentially have moved places, are no longer homeless. And so you can see how daunting these kind of larger outbreaks in high incidence settings can also be. So again, reasons I think to really think about TB screening and treatment and kind of building those partnerships well in advance of having an outbreak. And so I wanted to kind of give those different examples of the outbreaks that we've seen, and so that you can see how this may appear in your jurisdiction based on both your burden and also what your homeless populations may look like in your communities. So I want to just kind of skip ahead here and make sure Bobby gets his time. So just want to say contact investigations, we often do them around a case by having our contacts named. And in many situations, we have to actually go to location-based when folks have experienced homelessness. The use of incentives and enablers is not just recommended, I think it's almost mandatory. I think that has been a key to a tremendous amount of success that all of you actually have had in completion of treatment. We're well above 95% in our patients who are experiencing homelessness, but we know that comes at a tremendous amount of investment of resources, including incentives and enablers for almost all of you. The engaging local partners, what I would say to you is that having those relationships established ahead of having a problem is key. And so in a lot of these situations, the relationships came after these outbreaks occurred. But I think we know of lots of jurisdictions where there's continual kind of communication between shelters, housing first programs, a number of different homeless service agencies with the health department, and having that strong coalition ahead of time can often be the key to making sure one or two cases doesn't become an outbreak. I'm going to go ahead and skip these things and just kind of go to, you can, we'll be sharing these slides as soon as they go through the clearance process. But what is CDC and other folks doing right now? We unfortunately don't have enough scientific, evidence-based kind of interventions out there to rewrite official CDC guidelines. But if you go to look back at our 1992 guidelines, and I know those are old, they're actually still quite sound. And so if you need guidelines to really defend some kind of intervention or a resource, they're all there, and I really highly encourage you to use them even though they're old. We are trying to put more and more best practices out there. There are some things in the literature about administrative controls that we can always give you if you need that kind of support with a CDC stamp on it. I will say, and I wanted to highlight that in the 92 guidelines, we do talk about ensuring that patients who are diagnosed with infectious TB disease are housed. It is listed in that guideline. The vast majority of programs across the country are doing it. Everyone's doing it in slightly different ways. So sometimes they're nonprofits. Sometimes hospitals are helping to pay for housing outside a hospital. Sometimes it's the program itself has a budget to house folks, or it might be a partnership with another service agency. And so I encourage you to kind of know about how that works, even learn about how other programs are doing it if you would like, in order to do that. There's COE, our Center of Excellence products. There's shelter guidance. There's TB programs have written comprehensive plans. There's a lot of contact investigation advice out there for dealing with shelters and other homeless service agencies. And then some data management tools so that if you do end up in a situation where you have multiple contact investigations, how you can best work on that data. We have resources for you there too. So what can you all be doing? I mean, one, I would say share your experiences. So if you are in a jurisdiction where you had a big problem with this and you've had innovative or successful interventions, please share, publish, write abstracts, present it at conferences, share with your colleagues, because we have used each other a lot in learning how to do this the right way. And I think the more we have out there, the better for folks that are going through this for the first time. Document your housing status of all your patients. I really, really encourage you to not just ask what address they're staying at, how many addresses in the last year, have they ever stayed in a shelter, have they stayed in a shelter in the last 12 months. Try all sorts of different ways to try and get at this issue, because I think we don't document enough the true status of our housing status of our patients, and I think it doesn't accurately reflect the burden of the problem in the population. And then again, connect and coordinate with your providers. And I want to use that as our segue because one of the key partners out there is our Healthcare for the Homeless clinics. And I want to give Bobby some time to explain the amazing council and this network that is at your fingertips to work with. And we've had tremendous success in jurisdictions where we've directly partnered with our HCH clinics. And so I want Bobby to be able to tell you all about that agency.
Well, thank you very much, Sapna, and thank you, everyone, for your interest in this important topic and your investing of this time. And it's really an honor to be here with all of you. I thank the sponsors for this and for this opportunity. So we go to the next slide and just kind of tell you what the National Healthcare for the Homeless Council is. And it is a membership organization of the 300 Healthcare for the Homeless grantees, and also medical respite programs and other organizations that are concerned about healthcare for people experiencing homelessness. Healthcare for the Homeless programs are an official program funded by the federal government. I'll talk a little bit more about that. But one of the things I want to really emphasize to you is that treating people for their medical needs, for their behavioral health needs, while they are homeless, is extremely difficult. And the council represents a network of clinicians on the front lines, administrators, people with lived experience of homelessness that pool their information, pool their resources, their knowledge of how this can be done. So it can be done. It's difficult, but it's not impossible, and it's extremely important. So there is at least one Healthcare for the Homeless program in each of the 50 states, also in the District of Columbia, and there are 3 in Puerto Rico. They are federally qualified health centers that are supported by HRSA, and they meet all of the requirements for quality, for governance, for everything that a regular community health center has to do. But in addition, because of the special needs of the population, each one has to provide outreach services in some way, and they have to either provide or have an extremely strong linkage to mental health services and substance abuse services. One of the things that the council does is that it pools the information of its clinicians. We have about 2,000 clinicians on the front line. We call them that are in our clinicians network. They pool their information and they will adapt clinical guidelines for a particular disease and say, how can we take into account the reality of someone who is living on the streets or living in a shelter, and how can we adapt those clinical guidelines to their reality to make sure that we can have good health outcomes. I find it extremely valuable. I want to make sure that you know about that. We can move to the next slide. We'll just give a little bit of the history of the council. And I'm going to throw, if you can advance to the next slide, I'm going to throw in a little bit of a personal touch. In 1985, I was a live-in counselor at a rescue mission. I'm from New York City, and this was a live-in counselor at a rescue mission in New York City. And there were a lot of things going on right then in New York City. The AIDS epidemic was really at the forefront. There was a spike in tuberculosis, and we were really seeing multi-drug resistant tuberculosis for the first time in large numbers. And fortunately for me, there was a clinic at that rescue mission, and part of my job was to make sure it was a men's shelter, a men's rescue mission, that the men got to see the clinic, those who had special needs that we could see had health problems. There was a problem, and a public health advisor from the City Department of Health would come to test the men for tuberculosis, and they were having a hard time catching them. These were, most of them lived on the street. They would come in. There were more people who were served every day than resided in the rescue mission. We didn't have enough beds. So I became a TB skin tester. That was the state of the art. And between the public health department and the clinic, because I was there 24/7, basically, we're able to really test and follow up on the guys. And fortunately, we had quite a few with latent TB during that time, but no cases. So that clinic was funded by 2 foundations, Robert Wood Johnson Foundation and the Pew Memorial Trust, in a demonstration project in 19 cities, and those it was called the Healthcare for the Homeless program, as a demonstration project. It was extremely successful. And in 1986, 1987, when the federal government said, what can we do about healthcare for people experiencing homelessness? They were pointed to this model. They liked it. They adopted it. They grandfathered in the original 19 projects and added 5 more that were in Dr. Phil Brickner's shop, who was the overseer, who was the principal investigator of this project at St. Vincent's Hospital in New York. And that became the basis of the federal program, the Healthcare for the Homeless program. So I have a great vantage point of being around at the very beginning of that. And we can see that, to sum up some of what Sapna said, homelessness is dangerous to one's health. It kills. It takes extra care to find ways to deliver care for people experiencing homelessness. So the delivery of healthcare to people experiencing homelessness has changed over the years, and the Healthcare for the Homeless program has been at the forefront of that. So now there are 300 programs serving care to about 1 million people, 850,000 here. They provide care in different ways. Each one has a different model or a model. For instance, they all have to do outreach, but they may do it in different ways. The program I was associated with in New York we had a network of 30 small clinics, like the one at the Rescue Mission, in other shelters and soup kitchens and drop-in centers, provided street medicine by embedding a doctor or a nurse practitioner with a street outreach team, also had a mobile health clinic. Some programs in other cities will have fixed sites that are located in areas with high homeless populations. There has been a renewed focus on behavioral health in the mainstream health system, and this is an example where Healthcare for the Homeless programs were at the forefront. There are about 1,400 community health centers around the country that serve 27 million people. The 300 Healthcare for the Homeless programs serve about 1 million people, and yet, so we serve about 3% or so of all of the patients, but represent 38% of the patients that receive medical assisted treatment, which is the standard of care for substance abuse. So in many ways, by having to deal with the social determinants of health from the very beginning throughout their history, Healthcare for the Homeless programs are at the forefront and have many things to teach the overall health system. If we can move to the next slide, please. The one thing I will just kind of said, what Sapna said, almost every, well, without exception, every disease incidence or prevalence is found higher in people experiencing homelessness than among the general population. And people experiencing homelessness will often relegate non-emergent health care, such as for latent TB, behind more immediate needs, such as securing food, a place to eat, shelter. So cooperating, working with service providers, as Sapna mentioned, with shelters, so that their whole needs can be met, has been a keystone of the Healthcare for the Homeless program. We often will go where homeless people feel comfortable to make sure, and where their other needs are met, so that they will be able to use that as an entree to address their healthcare needs. We want to make sure that their needs don't progress to the case of becoming an active case of TB in this case, or any other kind of disease. We want to address it and prevent it as quickly as possible. Next slide, please. So just, Sapna said much of tuberculosis is overrepresented in people experiencing homelessness. You know, it is related to crowded conditions, but we don't think of we don't talk about TB outbreaks in college dorms, for instance, which are also congregate care settings. And it really is because of the population that is in the shelters or in the prison. People suffering from malnutrition, sleep deprived, higher rates of substance abuse disorders, all which compromise the immune system, which makes it hard to fight off an infection becoming active and multiplying within the body. Okay. That is my main point. Because of the poor baseline health, people experiencing homelessness are at higher risk for these diseases. And that's why it's important that we direct our public health prevention measures and intervention measures to populations such as those. Okay, next slide. Thank you. So I'll just wrap up with a few things. That just shows that we are all over the country. There are healthcare for the homeless programs all over the country. We also work with other regular community health centers that serve homeless people, even if they don't have a healthcare for the homeless grant, because our goal is that we want to eliminate homelessness, and we know we can't do that without addressing the healthcare of people who are experiencing homelessness. The map on the right shows medical respite programs, which Sapna made reference to. And this is something that is really important, especially for people who are ready to be discharged from a hospital but need a safe place to go. So medical respite is for people who are homeless, who have been in a hospital. They no longer have a clinical reason to stay in the hospital, but they're not healthy enough to return to their previous living condition, a situation, whether it's on the street or whether it's in a shelter or doubled up. So these programs and services are that intermediate step. They've been proven to not only be humane and help improve the health of the person who is experiencing homelessness, but also to save the medical system lots of money. It reduces readmissions into hospitals. It prevents conditions from deteriorating, so that by linking them up with primary care, by providing primary care medical services in the respite program. And it works best when it is a bridge to supportive housing or other housing, as Sapna made reference to under a Housing First model. I just want to, we can move to the next slide. I just want to mention a few things before talking about our federal partners, and that is just really to emphasize that it is possible to end homelessness. Sapna made reference to, we have made progress in some localities that even come to what they call functional zero in veteran homelessness in their city. We've made some progress in with various subpopulations, but the way we've made that progress is by targeting housing assistance, housing vouchers, rental subsidies, special housing with health care and other social services. That is the magic, that is the formula. It's not a secret. So we know what works. We just need to make sure we have the interventions that work at the sufficient scale, and that's a matter of the national will, political will. And we believe we can do that without spending much more than we are spending to serve people while they are homeless. So there are many people working together to serve people experiencing homelessness and working to eliminate and end homelessness. And Sapna made some of them. We work with all of them at the National Healthcare for the Homeless Council. And together, working with public health entities and public health departments, we can really make a difference in the health of our country and of our society. I will say that, I will conclude by saying healthcare for the homeless programs are housed in a number of different kinds of entities. Some are standalone, that's all they are as an organization. Others are part of larger community health centers. Some are in universities. A few grantees are in hospitals. and some are in public health departments around the country. At the National Healthcare for the Homeless Council, we will be glad to assist anyone to get connected to a Healthcare for the Homeless program near them, as well as we have a wealth of information, webinars, archives, documents on our website that are free and open to the public that we want everyone to know about and to use as needed.
Thank you so much, Bobby. Thank you so much. This is Sapna, and I am sorry that I talked too long, as I always do. But I really appreciate everything that you were able to share with participants. I'm sure Connie will echo that too before she gives us some questions. But I just wanted to say that for those of us that work in TB clinics, which I still do, one of the things I've noticed is that for my folks that may be uninsured or underinsured, or potentially even have problems with their document status here, when I've needed primary care support for the patient because they have so many other medical problems that at the TB clinic I cannot deal with, or I struggle to deal with, my Healthcare for the Homeless partner in my area, after developing a relationship with them, they have come to the rescue. They've been the ones where we can refer them. We work with them so that, they know about the TB status and what we're doing. We're able to give them the resources and partner with the Healthcare for the Homeless agency to provide the more comprehensive care that is so needed. And so I've found that, in certain TB clinics, we just don't have the ability to get some of that broader care because of how we're being more and more limited with our resources or with our, what we're able to do within the health department clinic system. So I just have to say that I think that in the most obvious one patient at a time approach, there's a tremendous benefit to having an established partnership. And then I think from a population standpoint or from a public health standpoint, partnering with our Healthcare for the Homeless agency and even shelters and our homeless agencies ahead of time can be a tremendous benefit on the back end if there becomes an issue with TB in our communities. So I'll just end there and give it back over to Connie. And thank you all very much for attending.
Hey, this is Connie. Sapna and Bobby, that was really, really amazing. I learned so much, and I'm really grateful that you guys were willing to help be our presenters today. I have a few questions, but I wanted to see, remind people that if you want to type in a question under the question or chat box, go ahead and do so, and then we'll ask our presenters these questions. Sapna, if I would also ask you to forward the slides to the resources, if you could just go forward. Can you guys hear me? Okay, there we go.
Yeah, I'm forwarding them.
Okay, great. I wanted to make sure I wasn't muted. So these, at the end of this presentation, you all will see that there's 3 slides that have links to different resources that were discussed during the presentation, also things that can be used for you in your programs and in your patient care services. And so the Curry Center Toolkit is there. There's a former webinar from the Mayo Center. There are tools for homeless service providers. There's some fact sheets on preventing homelessness. The CDC webpage on TB in the homeless population is there. And then some of the Outbreak MMWRs are there as well. There's also some infection control resources. And reach out to us. I certainly would appreciate anyone that needs help calling the SNTC. I know our other sister centers of excellence are always there to help, and CDC is there as well. And Sapna, one question for you is, if someone is working through an outbreak in their jurisdiction and wants to reach out and learn from others who've been through similar experiences, can they contact you or someone at CDC, maybe through their public health advisors, and get connected to other jurisdictions who've already worked through an outbreak among the homeless?
Yeah, and that's one of our main, one of our main functions in ways that we can help is to connect folks that have gone through this similar type of problem that you have, or that you may be experiencing at the time. We've seen a number of really innovative, successful programs in communities that have had outbreaks. And there are some jurisdictions that I know they don't mind us outing them, but New York has had a very unique approach, and not all of us are New York City, where we can have a Department of Homeless Services that changes kind of the whole. It's a transformative process that changes the whole approach to how services are delivered to our fellow citizens who are homeless. So, but there are places like San Francisco and Denver and Fort Worth, Texas, and Jacksonville, Florida, that have fundamentally, when they began to see a problem, changed their entire approach and have maintained their systems so that there's a direct communication between homeless service agencies and health department TB programs, and they've really curbed the problem in ways that they really don't see much burden of TB in their homeless at all. And there are examples of some jurisdictions who've implemented some phenomenal LTBI treatment programs, and so that they've been able to prevent, hundreds of cases by simply coming up with innovative ways to treat LTBI, particularly with the shorter course regimens. So one example that comes to mind is Mississippi. They did a tremendous job of bringing LTBI by 3HP, the once weekly 12 doses, to their shelters, and Cleveland did the same thing. And so they were able to, deliver the medicines at the shelter, monitor them, with DOT workers and nurses at the shelters, and get folks through 3 months of LTBI treatment and really reduce the number of cases that they saw in those communities. So we're happy to connect folks.
That is super helpful. There's a couple of questions now in the chat box, but I did want to ask one more question of Bobby, and that is just from a practical standpoint. You mentioned that the CHC has lots of resources and contact people, and you also mentioned that there's some clinical guidelines that have been adapted for the homeless population. So how would a program or an individual provider caring for a homeless patient access that to be able to get the assistance they might need for their patient?
Thank you. 2 ways. They both involve contacting us. You can go to our website, www.nhchc.org, as a National Healthcare Homeless Council.org, or you can email us or call us, and we have active TA. And if we don't have the answer, one of the great things about the council, it's a network of providers and people on the front line, and we easily can know who to call, who can contact you to give you some advice.
Oh, thank you. That's tremendous. And I will make sure when the slides come out that the website is part of the resources if it's not already. Sapna, one question that came up is when you were talking about incentives and enablers, are you referring to tools to support completion of treatment for active TB or for something else?
I was at that moment referring to use of incentive and enablers in completion of TB treatment. But I think that the concept goes, beyond that in the sense that in the most broad use of the term incentive and enabler, we've used that kind of an intervention in trying to identify further contacts. We've, thought about different things that we can do to assist a person to just be in a more secure and safe environment, whether that's food security or whether that's, just being in a safer place. It's actually very interesting. I've now seen this only a few times, and I certainly don't want to sound cavalier or insensitive, but there have been a couple of situations where I've heard patients kind of remark that TB was the best thing that ever happened to them, in the sense that we are unique. TB programs and TB providers are unique in that there are not many other kind of providers that really interact with someone on a day-to-day basis the way that we do, particularly early on in TB treatment. And so there has been some profound kind of positive benefits for having someone who has been potentially living, quite isolated, in, having that daily contact, and having that, even that kind of someone they've developed a relationship with, their DOT worker or their nurse, that really is looking out for their best interest and hoping to help them become healthier in every way, including treating their TB disease. And, it's pretty amazing when that temporary housing that's provided during the time that they're infectious, or maybe during intensive phase, can lead to applications to more permanent housing, or a time when there's enough brought to bear to help that person stop using their substance, because it's going to interact with their TB treatment, and we really need to provide resources so that they can not use during that time, and how that can be a bridge to making those changes more permanent. And so, we've kind of seen that before, where folks are like, wow, this time period, having that daily contact. I mean, I'm sure we've all heard about that too, sometimes like in diabetes care, where people really got a control of their diabetes because they had that daily contact with a DOT worker who is really delivering their TB meds, but providing that kind of overall attention to their health, really kind of had an impact. And so I think the concept of incentive and enablers certainly, again, I meant it around TB completion, but I think it does kind of go beyond that in terms of helping a patient maybe access some of those broader resources. And I think, again, it's hard to put the burden on the TB program to do all those things, but I think it is something that we can bridge people to if we know what the resources are and we know how to reach them. And so I think that's really where I see our role.
I think that's amazing, and I've kind of thought to myself, and again, not to sound cavalier, but patients who have HIV often have had more broad access to patient assistance. And so what I think I'm hearing from you and from Bobby is that there's actually much more that we can access for our patients with tuberculosis as well. And one follow-up question to that is, as a program who may not have current funding for incentives and enablers, how could we justify going to, the government entities, the state, whatever, and, when you're putting together your budget, to say, hey, we really do need these incentives and enablers because they will help our patients complete treatment, have better health outcomes, have less side effects, better monitoring, better engagement and care, so that all of the, eventually it is cost effective, I think. Do you have any advice for setting that up? Either one of you guys can answer that.
Well, I'll just say, as someone who ran an agency and had to deal with budgets, the incentives are such a minor part of the overall cost, and we know it really leads to greater patient engagement and therefore better health outcomes. When we did health education workshops, we didn't always give incentives because that was just part of our philosophy. But we knew that if we did not give any, we would, the attendance would be low, and we would lose opportunities to engage people. I think it's important, if you do give incentives, it should be something that will help promote health and reinforce the message. But it's extremely cost effective.
And so one thing just to encourage people out in the audience is, please share your resources, share how you have been successful at getting funding for incentives and enablers from, your administration. And sort of as an analogy, when the guidelines came out for using the gene expert to decrease decrease isolation inside hospitals, we've had now a publication, or a couple of publications are being worked on to show to hospitals buy the gene expert machine. It's cost effective because you can get patients out of the hospital and on treatment sooner, and save yourself a lot of money, or rule out TB sooner. If we could put together data that shows that using incentives and enablers really does help improve outcomes and save money, I think that would be a really important part of our resources to share, and keep our programs going. Another question came, does every state have a homeless council? And I think there's a map that showed that that's probably true. But Bobby, does every state have a homeless council, and would those be on your website?
Yes, every state has a healthcare for the homeless program. So if that's what the question means, yes. And yes, on our website there is a directory of that's organized by state. So you can search just freeform or go to the state and look for healthcare for the homeless programs in your state.
Okay, and again, that's www.nhchc.org.
And just to clarify too for the question, and Bobby, I'm sorry, I don't want to say you're the director, sir, but I think when we think about the relationship of the National Healthcare for the Homeless Council, which Bobby is the executive director, think of the relationship that DTBE may have to TB programs. So Bobby's shop, located in Nashville, right, Bobby?
Yeah, that's correct.
They serve as coordination. They do a lot of the CME. They help to provide a venue for all of these programs across the country to work together in advancing how they deliver care to homeless folks. They do advocacy. So the council itself sits as a national body to work with the various grantees that receive money to do healthcare for the homeless. So from our level, at the Fed level, working with Bobby's group has been amazing. We've even had situations where, let's just say, for example, there's a large outbreak and the jurisdiction TB program called us and said, hey, CDC, can you guys come and help us with the TB investigation? We've then called Bobby's agency, and they've had their counterpart in this same jurisdiction work with other homeless service agencies connected to Bobby's group, and how did they do it in a different jurisdiction? So while we're introducing our TB program to another TB program who's solved the same problem, the healthcare for the homeless groups are doing that amongst themselves and then learning how to build those coalitions. So we've often kind of worked together in providing those resources from the federal level to the local level to make sure that those relationships are kind of being formed and maintained. And so they've actually, we've worked directly with the council over the last 10 years in a lot of our outbreaks to make sure that all the parties are involved and everybody kind of knows what's going on. I hope that makes sense.
Yeah, that's super helpful. I want just one or two more real quick questions. Someone has asked about treatment completion of LTBI among the homeless community and what proportion of individuals who start, in particular 3HP, can complete therapy if it's directly observed. And maybe you would even give your personal thoughts on whether the new guidelines that say some patients can be given self-administered therapy, if you see that as being advisable in the homeless population.
So that's a great question, Connie. Thank you to whomever asked that. So we actually we have a manuscript that's cleared but not yet accepted for publication, where we looked at the 16 sites that did a post-marketing evaluation. We looked specifically at patients that were reported to be homeless that were given 3HP. Now, all of those were done by DOT, so they weren't done by self-administered therapy. We had about 380 patients in that cohort. We did add one or two big programs. I'll out them. LA had an incredibly robust program where they did DOT, shelter-based, and healthcare for the homeless-based 3HP delivery. And so they had a number of patients in that cohort. And what we showed was that the completion rate was right around 70%, which is phenomenal. If you look at the older data that's out there that looks at completion of 9H primarily, 6 and 9H, you know, we would see completion rates at 30% or less, certainly less than 50%, to the point where it wasn't cost effective for programs to try and get people experiencing homelessness through LTBI treatment. But now with 12 weekly doses or even 4 months of rifampin, we are seeing completion rates much higher, closer to general population numbers, at 70 or so %. We asked our folks, when I was involved in the writing of the 3HP by SAT guidelines that came out recently, and we've asked folks, we asked some experts and programs that had experience, would they try SAT with their folks who, you know, are experiencing homelessness? Most of them said they wouldn't. Most of them said that, one, it's hard to, in fact, many patients said they wouldn't want it that way because of the storage of medications, because, you know, the reminder to take it on a weekly basis might be difficult. You know, the use of combined incentive and enablers that almost all of our programs did when they did do 3HP to our folks that were experiencing homelessness. So because things were tied that way anyway, they seem to like the DOT. But the programs that were successful and had those high completion rates often did the DOT at the patient's location. So whether that were a shelter, where they did temporary work, it was less often at the clinic itself or a health department itself. So
is there any
I will make that caveat.
Any video DOT use?
Video DOT, not in that cohort, but in London, they did publish recently very successful use of video DOT 3HP, and not only just in people experiencing homelessness, but in people that had pretty tremendous substance use issues, and they were still quite successful. So it's interesting because these are often the patients that we exclude for video DOT. London specifically had a program targeting those populations that we would often exclude, and they targeted the use of video DOT, and they had really tremendous success. So I believe Dr. Story, S-T-O-R-Y, Alistair Story was the primary author on that, and I don't remember which journal it's published in, but if I'll find it, I'll make sure that we link to it when Connie sends out the link to the slides.
That's amazing. Okay, we are nearing the end of the question and answer period. I want to just comment on a few things. One thing I love about TV is how willing people are to share their experiences with each other. I think we're all in it together, and I see that Jerry Rogers has said that she can get incentives for food from food banks. She has a bakery that gives bread every month to help patients who are in need, and then she has small churches that she will reach out to and get some help with. And then another person commented that in Yuma, Arizona, homelessness of families, veterans, and individuals has increased in the last 2 years locally, and they have overfilled facilities. And then she, let's see, according to the map she provided, the closed agencies to assist. I'm not sure I understand this question, but are you aware of things in the Phoenix area that can be used for homelessness? Would that just be something that we could access on the website as well?
Was the question about incentives in the Phoenix area or health services?
In the Phoenix area, if someone wanted to find out what's available specifically in that area, is that something that they could contact you about or go onto your website? Do you want to provide any?
Yeah, we have a great health center, Circle the City in Phoenix.
Okay, that's great. And is that on your website?
Yes, it is.
Okay. Hey, I want to thank both of you again. I just think it's really important to show how the TB control world needs to work with other entities. When we're talking about social determinants of health, this is really right there in the middle of, one of the strongest examples of how we have to address a person's other needs as well as, their TB disease. And so wonderful to hear about this collaboration that CDC already has with HCH, and know that each one of us can also participate in that and look into your what resources are available. I want to remind people that this presentation will be posted in a few days or maybe a week or so after CDC has cleared it. And at the very last few slides are resources. We may add a few more to it now that we have some ideas about what people are interested in. And please feel free to send SNTC questions, or you can contact me directly, connie.haley@medicine.ufl.edu. I'm happy to help answer more questions or connect you to any kind of resources and assistance you might need. And please stay tuned for our next webinar. I believe that it is going to be November the 9th on a Friday, and it's going to be focusing on migration, overseas immigration. Drew Posey and GGMQ is going to put that on, and you will get an email about that soon. Linda, do you want to close up?
Yes,